Welcome back to the Deep Dive. Today, we are really strapping in for a high-stakes look inside the operating room. We're focusing squarely on vascular surgery, specifically aortic aneurysm repair.
Yeah, arguably one of the most demanding areas. High leverage, technically complex. It can define a career.
Absolutely. We're talking about the aorta, right? The body's main pipeline.
It is indeed. It's the major leagues of vascular care, you could say. And the margin for error, it's basically zero.
Life or death stakes.
Often, yeah. And frequently in emergencies. You need rapid, expert decisions right now.
That really sets the stage for our core mission today, doesn't it?
It does.
We've got this remarkable new multi-institutional data we've been looking at. And it forces us to ask a pretty blunt question.
Go on.
In this field, this demanding, evolving field, are the newest doctors, the graduating residents and fellows, are they truly practice ready when they get certified?
That's the million-dollar question.
And this study, it's a massive retrospective cohort study using national assessment data. The results, well, they're not just surprising.
No, they're more than that. They present a really serious challenge, I think, to how we train these high-acuity specialists. The whole structure.
Right. So to really get it, you, the listener, need to understand the background here. Vascular surgery is going through this fundamental shift.
It really is nothing short of a historic paradigm change. Our sources point out a couple of big trends happening at the same time.
Okay. What's the first one?
First, the total number of aortic aneurysm repairs being done surgically. It's actually going down.
Fewer operations overall. Why is that happening?
Well, the main reason seems to be public health success, actually. Decades of work reducing tobacco use.
Smoking, the big risk factor for aneurysms.
Exactly. So fewer people smoking means, over time, fewer aneurysms develop. And fewer aneurysms mean fewer opportunities for trainees to get that experience.
Huh.
Yeah.
That's a good thing overall, obviously. But it has this unexpected negative consequence for training, kind of counterintuitive.
It is. But there's a second trend, maybe even bigger. It's how we fix the aneurysms that do happen.
Okay.
The main technique has shifted, overwhelmingly, towards endovascular approaches, that's EVR, and away from the traditional open surgery, OAR.
The minimally invasive revolution. We've seen that everywhere, right?
Yeah.
Cardiology, orthopedics.
Exactly. But here's the kicker, the real bottleneck. It's not just a simple switch. The endovascular techniques themselves, they're getting way more complicated, rapidly, exponentially almost.
So not just the basic stent graft anymore.
Right. A basic EVIR is still common, sure, but increasingly we're seeing these really complex cases involving branch vessels, things like fenestrated and branched repairs.
Okay, hold on. Let's define that. Standard EVIR is usually below the kidney arteries, right?
Correct. Straightforward tube graft, relatively speaking.
So what makes these fenestrated and branched ones so complex?
It's all about location, location, location. When the aneurysm is higher up juxtarenal, meaning near the kidneys, or even thoracoabdominal, involving chest and belly aorta, it involves those crucial branch arteries.
Feeding the kidneys, liver, gut.
Exactly. A simple tube graft would cover those up. So fenestrated grafts have these custom-made holes, fenestrations. The surgeon has to line them up perfectly with the patient's arteries.
Wow.
And branched grafts. They have little side arms, like sleeves, that you have to steer wires and stents through into the target branch vessels.
Sounds incredibly technical. Needs perfect imaging, planning.
Meticulous planning, yes. Highly customized to each patient. And the source material we looked at, it notes these complex repairs went from basically 0% to making up a 23% of all aneurysm repairs in just 1 decade.
23%, that's a huge chunk and a massive technical leap.
It is. So think about the trainee now.
Okay.
The basic open procedures, the ones you absolutely need for emergencies, those are declining. And the new endovascular cases they are seeing, they're often so specialized, so complex.
That maybe the trainee isn't getting to do the key parts.
Yeah.
Or needs tons of help.
Exactly. Often requires multiple experienced faculty in the room. It creates this perfect storm, as you said earlier.
Yeah.
Not enough basic open experience. The stuff for urgent, catastrophic situations. And the endo cases they do see might be too complex for them to achieve real autonomy.
So this whole evolution, it naturally raises big concerns. Are they getting adequate training? Are they proficient? Across the board.
Precisely. And that's why this new study is such a big deal.
Because previous research just looked at numbers, case logs.
For years, yeah. Focused only on case volume.
Right.
And we've talked about this before on the show, right? Volume is just a proxy. It's just a number.
Tells you nothing about quality.
Yeah.
Or who's actually doing the work.
Exactly. Did the trainee assist on 100 cases, or did they actually lead 100 cases, making the key decisions? Huge difference.
So this study changes the game.
It's the first multi-institutional study we've seen that pivots. It looks directly at graduating proficiency.
Proficiency, meaning competence and autonomy.
Both. Using direct structured assessment data specifically for aortic surgery, it asks, could they actually do the case independently and well? Not just did they see it.
Okay, let's unpack the study itself then. What are we diving into here?
All right, so we're looking at a pretty powerful retrospective cohort study. The data comes from the SIMPL application.
SIMPL.
Yeah, the Society for Improving Medical Professional Learning. It's an app used for workplace assessments.
Yeah.
And this was a big sample, national, multi-institutional, 54 senior trainees, 50 faculty members, spread across 19 different training programs in the U.S.
19 programs, that's broad.
It is. And they collected data over 5 years, 2018 to 2023, ended up with 579 structured assessments of aortic procedures.
Wow, half a decade of real-world granular data.
Yeah.
Judged by faculty and by the trainees themselves.
Yes. Both perspectives were captured right after the procedures, right up to the point of graduation. For something this specialized, that's a huge data set.
Absolutely. So, give us the preview, the headline finding.
The core finding, the main takeaway. It's clear, and honestly, it's pretty stark.
Okay.
Trainees are significantly more likely to be rated as proficient in endovascular cases when they graduate.
And the flip side?
The flip side is a clear, measurable, and frankly concerning gap in their readiness for open aortic operations, the very ones they'll inevitably face in practice, especially emergencies.
Okay. That sets the stage perfectly. Let's dig into how they measured all this. Section 2. Understanding the metrics. We need to know exactly how success was defined here.
Absolutely. If we're going to critique training, we need to be crystal clear on the tools. The foundation, as I say, is this SIMPL or R application.
The smartphone app.
Right. Faculty uses it right after a case to rate the trainee, quick, in the moment. And a huge advantage of this tool, highlighted in the sources, is that the assessments are procedure-specific. They're tied directly to CPT codes.
CPT codes, the billing codes for procedures.
Yeah.
Why is that link so important?
Granularity.
Yeah.
It gives us real detail. It means the faculty didn't just rate aneurysm repair. They rated, say, endovascular repair of infrarenal AAA, that's one specific code, versus open repair of infrarenal AAA, a different code.
So you can directly compare apples to apples. The same clinical problem, infrarenal aneurysm, but the two different techniques.
Exactly. That level of detail is often missing in other assessment studies. It lets us isolate the difference in proficiency between the two foundational approaches for the same pathology. Really powerful.
Crucial detail, definitely.
Okay.
Okay, so two core metrics, autonomy and competence. Let's start with autonomy. How independent were they?
Right. Autonomy was measured using a well-known scale, the 4-level Swish scale.
Swish.
Now, this scale isn't really about rating how well they did the surgery. It measures how much independence the faculty gave the trainee during the operation. Basically, who was running the show.
Okay, walk us through the 4 levels. Maybe use that open infrarenal AAA repair as an example.
Sure, good idea. Level 1, the lowest, is show and tell.
Sounds like what it is.
Pretty much. Maximum faculty involvement. The attending might be saying, okay, watch me do the aortic cross-clamping. See how I expose this. I'm telling you the steps. The trainee is mostly observing, maybe holding a retractor, not doing critical parts.
Got it. Level 2.
Active help. Here, the trainee might be doing something more technical, like, say, dissecting around the aneurysm neck, but the faculty is right there, actively guiding every move, ready to jump in instantly, constant verbal cues, maybe hands-on assistance.
Still very supervised. What's next? This is where it gets interesting, presumably.
Exactly. Now we move into real learning territory. Level 3 is passive help.
Passive help.
This means the trainee is performing the key parts of the operation, maybe doing the main suture line, the anastomosis. The faculty is scrubbed in, standing right there, watching closely, but silently.
Okay.
They only step in if there's an immediate safety issue or maybe for a critical teaching point, but they're letting the trainee work through it.
Almost there.
And finally, level 4, the highest level, supervision only. This is it. This is the independent practice level.
Yeah.
The faculty is present, scrubbed, providing that safety net, but the trainee, they're running the entire show, managing all the steps, dealing with any minor issues, basically functioning like the attending surgeon.
That's the goal, right? Supervision only. That means you're trusted, you're ready.
Precisely. And here's a key point about this study's analysis. They set a very high bar for what counted as success here.
How so?
For their statistical analysis, they coded autonomy dichotomously, meaning it was either yes or no.
Okay.
And yes, being meaningfully autonomous, only counted if the rating was passive help or supervision only.
Ah, so levels 3 or 4.
Right. Anything lower show and tell or active help was coded as not autonomous. Their definition was basically, if you're not trusted enough for at least passive help, you're not ready for independent practice on this procedure.
Wow, okay. That makes the findings even more impactful if the bar is set that high. What about the other metric, competence? How well did they perform?
Competence was measured on a separate scale, a 5-level performance scale.
5 levels.
Yeah, ranging from the lowest, things like unprepared or having a critical deficiency, up through intermediate performance. But the key ratings for this discussion are the top 2.
Which are?
Practice ready and exceptional performance.
Practice ready. That sounds like the exact target for someone graduating.
Like this explicit goal of training, yes. And just like with autonomy, they coded competent dichotomously for the analysis.
So yes or no again?
Yes. You were coded as competent only if the faculty rated you as either practice-ready or exceptional performance. Anything less was coded as not competent.
So we're really looking at the intersection. Did they let you run the case, autonomy, and did you run it well enough to be certified competence?
That's the core question this data addresses.
Okay. One last clarification before we see the numbers. The study population, PGY 4s and 5s, residents and the fellows, why group them that way?
Right. The cohort was senior trainees, PGY 4 and 5 integrated residents, and all the fellows, which are typically PGY 6 and 7.
Okay.
The researchers grouped them based on comparable clinical experience, drawing on prior research. It turns out PGY4 residents who are deep into their dedicated vascular training often have a similar level of surgical experience as PGY6 fellows, who are maybe in their first year of focused vascular training after general surgery.
Makes sense.
And similarly, PGY5 residents were grouped with PGY7 fellows. Both represent the final year of their respective training pathways right before graduation.
So it ensures they're comparing proficiency at the cusp of independent practice, regardless of whether they did the integrated or the fellowship track.
Exactly. It isolates the proficiency question from the training structure debate to some extent.
Excellent. Methodology clear. Population defined. Let's get to the results. Section 3. The stark contrast. We're starting with the bread and butter procedure. Infrarenal AAA repair. EVAR versus OAR, head-to-head.
Yes, and this is where that paradigm shift we talked about becomes really, really obvious in the data. We're focusing here specifically on the final year of training that PGY5 PGY7 group.
Okay, the graduates.
The raw data, just the unadjusted numbers, show this massive, undeniable split in readiness between the two techniques for what everyone agrees is a foundational procedure.
Let's hit the autonomy gap first. Final year trainees. What were the numbers?
The autonomy gap is, well, it's huge. Trainees were rated as meaningfully autonomous. Remember, that's passive help or supervision. Only for 60.9% of the endovascular procedures, the EVAR zones.
Okay, 61%. So nearly 2/3 of the time, they're considered autonomous for EVAR. Seems reasonable for graduating seniors?
Seems reasonable, yes. Now, compare that to the open procedures, OAR. Autonomy was granted in only 21.1% of open procedures.
Wait, say that again?
21.1%.
Just over 1/5. In their final year of training.
Yes.
That's staggering. 4 out of 5 times, a senior trainee about to graduate is still not considered autonomous enough to handle a basic open intrarenal AAA repair.
That's what the faculty ratings show. They're still relying heavily on active help or even just watching the faculty do it right up until they're supposed to be independent.
This isn't just a small deficit, then. This sounds like a systemic failure to achieve even baseline readiness for a core open skill.
It is truly sobering data. That 21.1% figure strongly suggests that, as a group, they're not consistently reaching independent practice readiness in OAR, even for this fundamental procedure.
And the implications. Think about it. They graduate, go into practice, maybe somewhere without immediate senior backup.
Right. A community hospital, perhaps?
And they face an emergency, a ruptured AAA, which often requires open repair.
The classic vascular emergency.
If they were only autonomous 21% of the time, with faculty right there, what happens when they're alone at 2 a.m.?
That's the critical question. It raises serious concerns about their ability to handle that situation safely and effectively. Getting that proximal aortic control quickly in a ruptured case, it's everything.
And if they hesitate or struggle, the consequences are dire. This 21% suggests a massive skill gap, likely tied directly to that drop in open case volume.
And the competence gap, how well they performed it, mirrors this exact same problem.
Okay, what were the competence numbers for the final year trainees?
For endovascular procedures, EAR, they were assessed as competent, practice-ready, or exceptional in 50% of cases.
Half the time for EVAR and for open OAR.
They were assessed as competent in only 22.2% of open procedures.
Wow. So 50% competence for EVR, but only 22% for open. Again, less than a quarter.
It confirms the pattern. We seem to be graduating surgeons who are reasonably proficient in the modern common technique, EVR.
But critically deficient in the traditional, but still essential open technique, OAR.
And notice how close the autonomy and competence numbers are for OAR. 21.1% autonomous, 22.2% competent.
Yeah, they're almost identical.
Which suggests the faculty are linking them, right? They're not granting autonomy because the performance isn't consistently at that practice-ready level yet. It makes sense.
It does. It paints a consistent, concerning picture. Now, you mentioned the training structure integrated versus fellowship. Did that make a difference here?
That's a really important secondary finding. The study specifically compared the integrated residents, PGY-45, with the fellows, PGY-67.
Yeah.
And the sources state very clearly there were no statistically significant differences in competence or autonomy between the two pathways for these aortic procedures.
None. So it doesn't matter if you did the 5-year integrated track or the 7-year fellowship track, the outcome regarding this proficiency gap was the same.
That's what this data indicates. It suggests the problem isn't caused by the specific structure of the training program.
Which means you can't just blame one pathway or the other.
Exactly. The deficit seems systemic. It's likely driven more by that overall lack of clinical exposure to open cases, the shift in practice patterns we discussed. It transcends the training structure itself. It's about the content and opportunity within the training environment.
Okay. That's huge.
Yeah.
Now, let's bring in the perception piece for these infrarenal cases.
Yeah.
How did the trainees see their own skills? We know the faculty data says they're often not ready, especially for open. Did the trainees agree?
This is where the data gets really fascinating and, frankly, a bit alarming from a safety perspective. It's about self-awareness.
Right.
For the endovascular cases, EVAR, the trainee self-assessments, were generally pretty similar to the faculty ratings.
Okay. How close?
Trainees rated themselves autonomous about 55% of the time, competent about 46%. Faculty rated them 61% and 50%. So, in the same ballpark. Reasonably aligned on EVR readiness.
Okay. They seem to have a realistic view of their endo skills. But the open cases, OAR.
That's where the disconnect happens. For open cases, the graduating trainees perceived having significantly higher levels of both autonomy and competence than their faculty rated them.
Higher. How much higher are we talking? Give us the numbers again.
Trainees self-assessed their autonomy for open infrarenal AAA at 39% and their competence at 38%.
Okay, wait. Let me make sure I have this straight. Faculty, autonomy 21%, competence 22%. Trainees, autonomy 39%, competence 38%.
That's correct.
That's almost double. They thought they were ready, or close to it, almost twice as often as their mentors did.
It's a massive gap in perception, nearly an 18 percentage point overestimation on both fronts. It's not a minor disagreement. It's a fundamental disconnect from the faculty's assessment of their readiness.
Wow. What does that imply?
It suggests a potentially dangerous blind spot, a lack of accurate self-reflection regarding their open aortic skill set.
And the risk is?
The risk is, if they graduate believing they're close to 40% ready for independent open repair, when the faculty reality is closer to 20%, they might take on complex or emergent open cases early in their practice without seeking the help they actually need.
Because they don't realize they need it.
Precisely. That overconfidence based on inaccurate self-assessment could lead to delays in consultation or attempting procedures beyond their true capability, potentially impacting patient safety.
That's a sobering thought. The clinical safety time bomb, as you put it earlier. Okay, let's broaden the scope now. Section 4. We looked at the basic infrarenal AAA. What happens when we look at all aortic procedures?
Right. This category includes everything: thoracic aneurysms, abdominal aneurysms, dissections, occlusive disease, all indications. Open and endo. It's a more complex data set based on all 579 assessments.
Gives us a wider view of their overall aortic experience in these academic centers.
Exactly, where they see the full spectrum from elective bypasses to urgent stent grafts for dissection.
So looking at the final year trainees again, what did the faculty assessments show for this broader category? Did the open endo gap persist?
It did persist, although the absolute number shifted, interestingly. For all endovascular cases combined, final year faculty ratings were autonomy 58%, competence 49%.
Okay, slightly lower than for infrarenal EV alone, which was 61% and 50%. That makes sense if this includes the really complex endo cases.
Exactly. Those super complex fenestrated and branched repairs likely pulled the average down a bit. Now, for all open cases combined, autonomy was rated at 41% and competence at 37%.
Whoa, hang on. That's higher than for infrarenal OAR alone. Remember, that was only 21% autonomy and 22% competence. Why would the open scores go up when you include more complex open procedures? That seems counterintuitive again.
It does at first glance, but there's a contextual insight here suggested by the sources.
Okay.
It implies that the open aortic cases trainees are getting experience with now are maybe more varied than just the classic infrarenal AAA repair. They might be doing more open procedures for things like aortoiliac occlusive disease, think aortobifemoral bypass grafts.
Ah, bypasses for blockages, not aneurysms.
Right. These can be very complex surgeries, definitely major open aortic work, but they're often elective procedures.
Planned, stable patient-controlled environment.
Exactly. More conducive to teaching, perhaps allowing trainees to achieve higher levels of autonomy and competence compared to the high-stress, unpredictable nature of an infrarenal AAA repair, especially a ruptured one.
So the argument could be made that they're getting decent open aortic experience just on a different set of pathologies.
Yeah.
And maybe those skills transfer.
That's likely the interpretation. They are gaining some proficiency in open aortic maneuvers through these other cases. But, and this is a big but,
Yeah.
can you really equate the skills for a planned elective aortobifemoral bypass in a stable patient with managing a catastrophic, bleeding, ruptured AAA?
That's the critical question. The decision-making, the speed, managing massive blood loss, getting that proximal control under pressure, it feels fundamentally different.
It is fundamentally different. So while this data suggests they might be getting more varied open volume, which boosts the overall open proficiency numbers somewhat,
They're still lagging way behind their endovascular skills.
way behind. Even with this boost, look at the final year numbers again for all aortic. Open autonomy 41%, endo autonomy 58%. Open competence 37%, endo competence 49%. The gap is still very large and significant across the board.
The divide persists, no matter how you slice the open category.
Okay.
Now bring in the heavy artillery, the statistical modeling.
Right, the model-based prediction. The researchers use what's called a mixed effects logistic regression model. This is where we get the really robust statistical proof because it accounts for confounding factors.
Why is this kind of model needed? Why not just use the raw percentages we just discussed?
Because surgical training data is messy, right? You have trainees within programs rated by different faculty members in different hospitals, lots of layers. A trainee might get lower scores. Is it because they're truly less skilled? Or maybe their main faculty mentor is just a really tough grader compared to others. Or their program sees fewer complex cases.
So the model tries to filter out that noise, like rater bias or program differences.
Exactly. The mixed effects model adjusts for these potential biases, the nesting of trainees within faculty, faculty within programs, even the timing within the academic year. It gives us the cleanest possible prediction of proficiency, specifically at the moment of graduation.
Isolating the true effect of the procedure type open versus endo on predicted proficiency at graduation.
Got it. So what did the model predict based on faculty assessments?
This is where the statistical evidence really underscores the severity of the open skills gap. The faculty assessment model produced highly significant findings, predicting proficiency right at graduation.
Give us the odds ratios and explain what they mean. Okay. The model predicted that graduating trainees are significantly less likely to achieve meaningful autonomy in open procedures compared to endovascular ones. The odds ratio, the OR for autonomy in open procedures, was 0.25.
0.25. So if the odds of being autonomous in an endo case at graduation are, say, 1, the odds of being autonomous in an open case are only 1/4 of that.
Precisely. Statistically, they are 4 times less likely to be deemed meaningfully autonomous in open aortic surgery compared to endovascular surgery at the point they finish training. It's a statistically powerful confirmation of that gap across the entire data set, controlling for other factors.
Devastating statistic for readiness and open skills. What about competence, practice readiness?
Same pattern, equally concerning. The model predicted trainees were also significantly less likely to achieve competence that practice-ready or exceptional rating in open procedures. The odds ratio here was 0.32.
0.32. So roughly 1/3 as likely to be rated competent in open compared to endo.
Correct. Even after adjusting for rater variability, program differences, and seniority, the model confirms this major proficiency divide with high statistical confidence.
This really drives home the point that just tracking case volume isn't enough, doesn't it? The volume isn't translating into the necessary competence and autonomy for open skills.
It's strong evidence that relying solely on volume metrics is becoming obsolete for ensuring readiness in this changing landscape. The outcomes just aren't there for open surgery.
Okay, now the critical comparison. How did the trainee self-assessment model fare in this statistical analysis? Did they also predict lower proficiency for themselves in open cases?
They did, but with a crucial difference. The trainee model did predict they were significantly less likely to self-assess as autonomous in open procedures. The OR was 0.39.
Okay, 0.39. So they recognize some lack of autonomy in open, rating themselves less likely to be autonomous there compared to endo, still higher than the faculty's 0.25, but directionally similar.
Right. They perceived a gap in autonomy, just not as large a gap as the faculty perceived. But here's where that competence overestimation we saw earlier really plays out statistically.
Ah, competence. What did their model predict there?
This is the kicker. The trainee self-assessment model showed no statistically significant difference in the predicted odds of achieving competence between open and endovascular procedures at graduation.
Hold on. No difference. The model showed they rated themselves as equally likely to be competent in open surgery as in endovascular surgery when they graduated.
That's what the adjusted model showed for trainee self-perception of competence. Flat odds ratio, essentially 1.00, not statistically different.
But the faculty model showed they were only 1/3 as likely to be competent in open, or a 0.32.
Exactly. This is the ultimate statistically validated perception gap. The faculty sees a massive deficit in open competence readiness. The trainees, on average, believe their competence level is effectively the same for both open and endovascular techniques right as they're heading into practice.
That is profoundly concerning. It statistically confirms that dangerous disconnect. They don't see the competence gap that their mentors clearly do.
It reinforces the safety concerns we discussed. If you think you're equally competent, why would you hesitate or seek help for an open case?
Which leads us right into Section V, the critical perception gap. We need to understand why this disconnect exists, what's driving it.
The source material dives into this, identifying two distinct patterns in these self-assessment discrepancies. It's almost like mirror images depending on the procedure type.
Okay, let's start with the one we just highlighted. Open cases, where they overestimated themselves.
Right. For open procedures, particularly those infrarenal repairs, trainees consistently rated their autonomy and competence higher than faculty did. We saw it in the raw numbers, and the model confirmed the competence overestimation.
Why might that be? What are the theories?
This study authors suggest a few possibilities. One is, maybe graduating trainees feel a certain pressure, an obligation almost, to report readiness as they transition to practice. It's expected, right?
Like, I'm graduating? Of course I'm ready. A bit of self-convincing.
Could be part of it. Another idea is that because open cases are rarer now, when trainees do get involved in one, maybe they feel a heightened sense of participation and importance. This could lead them to inflate their perception of their own contribution and control, even if the faculty was actually providing significant guidance during the critical steps.
Interesting. Like, I was really in the thick of it, even if they weren't truly leading.
Possibly. It's hard to be objective about your own role in a complex, infrequent event. The clear consequence, though, is that they might enter practice not fully recognizing the limitations in their open skill set.
That lack of self-awareness again. Believing they're at 38% readiness when the objective faculty assessment is closer to 22%. Big implications for seeking mentorship early on.
Huge implications. Now, the flip side is fascinating, too. For the complex endovascular skills.
They underestimated themselves compared to faculty. Why would that happen?
Yes, this discrepancy popped up mainly in that combined all-aortic procedures data, which includes those super complex fenestrated and branched EVARs, FBVAR.
Okay.
The thinking here is it might be tied to the sheer nature of these procedures. They are often incredibly intense.
How so?
Well, they can be very long, technically demanding, using cutting-edge, sometimes unfamiliar, very expensive custom devices. And crucially, as we mentioned, they often require two senior faculty members working together.
The double attending scrubbed in.
Right. Imagine being the trainee in that environment. The pressure, the complexity, the cost, multiple attendings watching every move.
You might feel less in charge, less autonomous, even if you're doing the technical steps correctly.
Exactly. The trainee might feel like they're operating under a microscope. So even if the faculty rates their technical skill highly, like, wow, they cannulated that renal artery branch perfectly, the trainee might still rate their own autonomy lower because they didn't feel fully entrusted with overall control due to the intense oversight and the high stakes.
So it's less about technical skill doubt and more about the feeling of entrustment or lack thereof in that specific high-pressure setting.
It seems plausible, a sort of performance anxiety related to the magnitude of the case, rather than a true underestimation of their capability to perform the steps.
That's a really insightful distinction. It shows autonomy isn't just technical skill. It's also about that feeling of control, responsibility, and trust in the OR environment.
And this whole dichotomy, overestimating, open, underestimating complex endo, forces a discussion about the assessment tools themselves. How good are they at capturing reality?
Right. The study used SIMPL. How does it fare in this context?
The study acknowledges that simple assessments, while great for getting that specific CPT code data we needed for this analysis, they have historically shown somewhat poor alignment between trainee and faculty ratings, which is exactly what we just discussed seeing here.
So part of this perception gap might just be noise in the assessment tool, or how trainees interpreted scales versus faculty.
It's likely a contributing factor. We have to be balanced. SIMPL gives us granularity, but maybe it's not the best tool for capturing that nuanced concept of entrustment.
Entrustment, okay.
The source material contrasts SIMPL with newer assessment frameworks, specifically entrustable professional activities, or EPAs.
EPAs.
Yeah.
Heard of those. How are they different?
EPAs are designed differently. They focus more holistically on entrustment. It's not just rating isolated skills, but making a judgment about whether the trainee can be trusted to perform a larger clinical task independently and handle potential complications. It tries to combine autonomy and performance into one overall assessment.
Can you give an example? How would an EPA for, say, open AAA repair differ?
Instead of just rating anastomosis skill or autonomy level, the EPA assessment might ask the faculty something like, based on today's performance and your overall experience with this trainee, how much supervision would they need to manage an emergent rupture AAA presentation at 3 a.m.?
So it's a much broader, higher-level judgment call about readiness for real-world scenarios. It directly asks about trust.
Exactly. It's about trusting them to handle the whole event, including the unexpected, maybe without you physically there, or at least without needing immediate intervention. That's a higher bar than just rating steps in a controlled setting.
And do EPAs show better agreement between trainees and faculty?
Interestingly, yes. The sources mention that EPAs have demonstrated considerably better rater agreement in vascular surgery compared to what's typically seen with SIMPL assessments.
That's crucial. If both sides agree on the level of readiness, the level of entrustment, then training goals become clearer. And that risk of the graduate overestimating their skills in a crisis goes down.
It seems like a promising direction. So the conclusion on assessment tools. It seems that while SIMPL gave us this incredibly valuable procedure-specific data for this study, moving forward, the best approach might be integrating multiple types of workplace assessments.
Like combining the granularity of SIMPL with a better rater alignment and focus on entrustment from EPAs.
That seems to be the suggestion. Get the best of both worlds to get the most accurate picture and shape future training effectively.
Makes perfect sense. Okay, we've established the gap, quantified it, explored the perception issues. Now, the crucial part. Section 6, the way forward. If proficiency in open surgery is lagging and case volume isn't coming back, what are the real actionable solutions? How do we ensure new surgeons are ready for those inevitable open emergencies?
Right. This is the what do we do now part. And it's a recognized issue internationally, not just in the U.S. The sources lay out 3 main solutions, recognizing that just hoping for more cases isn't going to cut it. We need structured compensatory strategies.
Okay, solution number 1 seems the most obvious. Surgical simulation.
Absolutely. The study strongly advocates for routine, dedicated, and importantly, high-fidelity simulation. If the clinical exposure isn't there, this is really the only scalable way to tackle the problem directly.
Create the experience if you can't get it on real patients. How realistic can these simulators get for something like open aortic surgery?
They're getting incredibly sophisticated, way beyond simple plastic models. The study mentions using advanced 3D printing to create aortic models that feel realistic.
Haptic feedback, mimicking tissue feel.
Exactly. Models that can replicate the feel of a diseased aorta, the calcification, how fragile the tissue is, the resistance when you try to clamp it.
Okay. What's a critical open skill simulation absolutely must address for this problem?
The single most critical skill in an emergent open AAA, especially a rupture, is achieving proximal aortic control, getting that clamp on safely and quickly above the aneurysm.
In a potentially chaotic, bloody field.
Precisely. The anatomy is distorted, time is critical, patient is crashing. Simulation lets trainees practice that high-stress maneuver repeatedly, identifying landmarks, feeling the vessel, learning the clamping technique, all without patient risk.
Practice until it's almost muscle memory.
That's the idea. And the source mentioned great work being done elsewhere, like colleagues in transplant surgery in Toronto developing similar low-cost, high-fidelity models for complex vein connections. It shows this is feasible and doesn't have to break the bank.
And if you can reliably simulate it, you can potentially measure proficiency in simulation, right? Move away from just counting cases.
That's the ultimate potential. Imagine setting a standard. Trainee must demonstrate successful proximal control in a simulated rupture scenario within X seconds Y number of times. That's a proficiency benchmark, not a volume count.
A true competency standard. Okay, simulation is key. What's the second proposed solution? It sounds like it addresses the concentration of expertise.
Specialized training. This one acknowledges the reality that complex aortic surgery, both open and endo, is increasingly being done at high-volume centers.
So not every hospital, not every surgeon is doing a lot of these anymore.
Right. So one idea is to consider developing accredited aortic superfellowships, or less formally, just encouraging and supporting the concentration of complex aortic care among surgeons who've trained or practiced at these high-volume centers.
Super fellowships.
Yeah.
Like an extra year or two focused just on aortic surgery after the regular residency or fellowship.
Exactly. These are already emerging, often supported by surgical societies and industry partners. They offer dedicated, advanced training, maybe clinical, maybe workshop-based, lasting months to years, really honing those complex aortic skills.
So it's like a safety valve. If you graduate with that 22% competence in open repair, but you want to make complex aortic work a focus of your practice, this provides a path to get there.
It's a necessary pathway, acknowledging that the standard training duration might not be sufficient anymore to achieve mastery across all aspects of vascular surgery, given the changes. It allows for specialization.
But the goal is still for everyone graduating to be competent in the basics,
Right.
especially basic open repair for emergencies.
Absolutely. The sources emphasize that. The ideal is still for all graduating vascular surgeons to be proficient in managing common, urgent, and emergent aortic problems, including open repair. The super fellowship is more for the super specialized, complex, elective work.
Okay. Which brings us to the third solution. And this seems crucial, given that perception gap we discussed, the trainees thinking they're more ready than they are.
3, ongoing mentorship. This cannot be stressed enough because the data suggests graduating trainees may not accurately recognize their limitations and open skills.
Right. That 38% self-rating versus 22% faculty rating.
Having strong mentorship from experienced partners or colleagues during those first few years of independent practice is absolutely critical.
How does that work practically? What does that mentorship look like?
It functions as both a safety net and a continuous learning opportunity. An experienced mentor can provide a crucial second opinion on a challenging case. Maybe they can encourage the new surgeon to transfer a particularly complex patient, or even just be available to scrub in and assist or advise during their first few emergent open cases.
Kind of like training wheels extending into early practice.
In a way, yes. It ensures patient safety while allowing that early career attending to continue developing their skills in a supported environment, not learning solely through high-stakes trial and error. It helps bridge that gap between perceived competence and actual competence.
And it provides that objective voice to challenge the potential overconfidence from the self-assessment bias.
Exactly. Having someone trusted say, hey, maybe we should think twice about tackling this one alone, or let's review the images together, can be invaluable. It helps ensure the right procedure. Sometimes the more difficult open one gets done when it's truly needed, rather than defaulting to endo just out of comfort.
That seems essential until their self-assessment calibrates with experience. Okay, those are 3 big solutions for the open side. But before we conclude, we have to touch on the endovascular side again. Because even though proficiency was higher there, those final year numbers for all aortic endo, 58% autonomy, 49% competence, they still seem kind of low for graduating specialists, don't they? If endo is the future, why aren't those numbers in the 80s or 90s?
That's the other side of the training coin, the second major challenge. We know the straightforward EVAR exposure might be declining.
Replaced by these super complex FBVR cases.
Exactly. And as we discussed, that very complexity, especially with multiple faculty scrubbed in, tends to inhibit trainee autonomy.
They might be doing steps perfectly, but never get handed the reins.
It's harder for faculty to step back to supervision only when the procedure is that intricate, the device is that expensive, and the potential for error is so high. So even endovascular proficiency is facing challenges, particularly at the highest levels of autonomy and for the most complex procedures.
So what's the suggested solution for improving the endovascular training experience, especially for those complex cases?
The clear implication from the sources points towards collaboration. Specifically, working closely with industry partners, the companies that make these complex grafts and delivery systems.
How can industry help?
They can play a huge role in education, developing dedicated simulation modules specifically for their devices, running focused workshops on the tricky technical aspects, like cannulating target vessels or planning fenestrations, creating opportunities for trainees to get hands-on practice with the equipment outside of the high-pressure OR.
So leveraging industry expertise and resources to supplement the clinical training for these advanced techniques.
Exactly. It's about finding ways to maximize the learning yield even within these complex, multi-faculty procedures, ensuring trainees gain identifiable, meaningful experience with the technologies they'll be using.
Okay, that gives us a pretty comprehensive strategy then.
Yeah.
Simulation for the low-volume open skills. Specialized training pathways for the super complex stuff. Mentorship to bridge the gap into practice. And industry collaboration for the high-tech endo training.
It's a multi-pronged approach, a necessary adaptation, really, if we want to ensure graduates are truly prepared for the realities of modern aortic surgery, both open and endovascular.
Right. Let's bring it all together. Section 7. Conclusion and our provocative thought. Summarize the core findings for us one last time.
Okay. In summary, this big multi-institutional data set, using the SIMPL assessment tool, confirms a major issue in vascular surgery training. Trainees are graduating significantly more proficient in endovascular aortic repairs compared to open ones. That's clear.
But the key is the level of proficiency, especially for open.
Exactly. The really critical finding is the overall low proficiency in open aortic surgery, particularly for foundational procedures like infrarenal AAA repair, where competence was only around 22% at graduation. That's concerningly low.
And this documented lack of readiness is made worse by that perception gap. Trainees think they're considerably more competent in open surgery than their faculty mentors rate them.
Yes. That disconnect poses a significant potential safety risk as they transition to independent practice.
So what's the central relevance here? Why does this matter so much?
Well, the concern is that this combination, lower proficiency in open techniques plus an overestimation of one's own skills, could actually influence clinical decision-making.
How so?
A surgeon who isn't comfortable with open repair or perhaps overestimates their ability to handle it might develop a bias. They might lean towards recommending an endovascular approach, even in situations where open surgery might be clinically better or even necessary. Think about certain rupture scenarios or specific patient anatomies.
So the surgeon's comfort level, driven by training gaps, could potentially dictate patient care rather than purely clinical factors.
That's the worry. Patient care should always be based on what's best for the patient, not just what the surgeon feels most comfortable doing. This research highlights why maintaining proficiency in both modalities is so vital.
Which underscores the need for those solutions we discussed, especially ongoing mentorship early in practice as that crucial safety net.
Absolutely. Mentorship, plus innovation in training like high-fidelity simulation, are essential to proactively bridge these skill gaps identified by the study.
It's really a call to action, isn't it? For surgical education leaders, for programs, for certifying bodies to adapt, to face the reality of modern practice where essential open skills are needed but rarely practiced, while complex endo skills are common but hard to teach autonomously.
It demands a rapid evolution in how we train and assess vascular surgeons.
Okay, that leads us perfectly into our final provocative thought for you, the listener, to chew on. We know the goal is readiness, especially for emergent open aortic surgery. But the clinical volume just isn't there like it used to be, and simulation, while promising, is still evolving.
So here's the question. Given the rising complexity of endovascular techniques and the undeniable decline in open repair volume, should the entire field maybe shift its focus?
Shift from what to what?
Shift away completely from tracking case volume, which this study strongly suggests is a flawed metric for actual proficiency, and move towards setting a mandatory minimum proficiency standard for graduation.
A standard measured how? Through simulation. Standardized testing.
That's the challenge. If we set that standard, especially for open aortic surgery, what would that measurable criterion actually look like? How do you define and reliably assess competence for a critical life-saving skill that a surgeon might perform very infrequently in real life, but has to be ready for at a moment's notice?
How do you certify readiness for a necessary skill that might lie dormant for years, but needs to be perfect when called upon in an emergency?
That's the ultimate question, isn't it? Defining that competency floor when the traditional volume-based experience has fundamentally changed. That's the puzzle facing graduate medical education and vascular surgery today.
A challenging puzzle indeed. Thank you for navigating this critical and quite sobering data with us today.
My pleasure. Important discussion to have.
That's all the time we have for this deep dive. We'll catch you next time.